That may have been for you.
Okay, good. I see. Thanks.
Good morning. Good morning. My name is Mike Van Dusen. I'm Deputy Director of the Woodrow Wilson Center, and I want a hearty welcome to all of you to be here today. It is a happy morning for another occasion. The third of 4 Iranian Americans who's been detained in Iran was released this morning. We hope very much that the 4th will be released shortly, and we revel in the fact that Hala Esfandiari, the director of our Middle East program, is back at work after 8 months of detention. The President's statement in late May reauthorizing Pepfar for when it would expire at the end of fiscal year 2008 sets the stage for today's meeting. And in that reauthorization, there's a commitment to redouble the effort, I believe, from the initial 15 million to 30 billion, over 5 years. That is a very strong commitment. We're very happy to have today the key players to talk about this important issue. Congresswoman Nita Lowey is currently serving in her 10th term in Congress, and she's chair of the State and Foreign Operations Subcommittee of the Appropriations Committee. Madam Chairman, welcome to the Center. She is also a member, I believe, of the House Homeland Security Committee. In those roles, she's been a leading advocate of increased federal investments in biomedical research on diseases like cancer, diabetes, and Alzheimer's at the National Institutes of Health. And she has worked to increase access to health care, improve first responders' preparedness and equipment, and improve avian flu pandemic preparedness. Before being elected to Congress, she served as Assistant Secretary of State for the state of New York. This is Dr. Peter Piot's 3rd visit to the Woodrow Wilson Center. Peter, welcome back. Dr. Piot's been the executive director of UNAIDS for, I believe, a dozen years. Drawing on his academic and scientific career, focusing on AIDS and women's health in the developing world, Dr. Piot has challenged world leaders to view AIDS in the context of social and economic development as well as security. After graduating from medical school in the 1930s, Dr. Piot the 1970s.
I really look good.
Yeah. I just gave you 50 years.
It's a bit,
Dr. Piot co-discovered the Ebola virus in Zaire in 1976. And in the 1980s, he worked on Project CETA in Kinshasa, Zaire, which was the first international project on AIDS in Africa and widely acknowledged as having provided the foundations for our understanding of HIV infection in Africa. Dr. Kenneth Hill of AID is our 3rd speaker, and he comes back to the center having been here last week. Welcome back. I believe he has just about been in his position as Assistant Administrator for the Bureau of Global Health for 2 years, and before that served for roughly 4 years as Assistant Administrator for the Bureau for Europe and Eurasia at USAID. His bureau in fiscal year 2006, that's old, I guess, managed or co-managed health programs all over the world with funding of more than $1.8 billion. Prior to coming to USAID, Dr. Hill served as president at East Nazarene College, I believe, in the state of Massachusetts, and as president of the Institute on Religion and Democracy here in Washington. He has also taught European and Russian history at Seattle Pacific University. He's a noted expert on democracy, international development policy, human rights, and international religious freedom issues. Chairwoman Nita Lowey will speak first.
Good friends.
And Nita Lowey will speak first, and followed by Dr. Piot, and then Dr. Hill. And Dr. Jeff DeBelko, the Woodrow Wilson Center, will moderate the discussion from there on. Congresswoman, welcome to the center.
Thank you for that kind introduction. And Lowy merged with Pelosi is just fine. Actually, our careers have been interesting because we've been in the Congress together for 20 years, serving on what was then the Foreign Ops Committee and the Intelligence Committee, on which I also serve, except I can't talk about anything that I do there. And I must say, it is great to be in the majority. And it's very nice to be the chair and to have the first woman Speaker of the House. So you can do that anytime. Thank you very much. I want to thank Dr. Piot from UNAIDS, Assistant Administrator Kent Hill, for joining me today for what I hope will be an important dialogue on the future direction of U.S. government assistance in fighting the global HIV/AIDS pandemic. We all know the statistics, but they are certainly worth repeating. 39.5 million people living with HIV/AIDS around the world, 4.3 million new infections in 2006, an estimated 32 million deaths since the beginning of the pandemic. 8,500 people die of this disease daily. These statistics really are breathtaking, and they could have been paralyzing, but instead, when the American people learned of the suffering caused by this pandemic, we resolved to make a difference. And 5 years ago, under the leadership of many committed individuals and organizations, Pepfar was launched. 5 years later, we can be proud of what it has accomplished. Pepfar set a new tone for the global response to the HIV/AIDS pandemic. In choosing to addressing the need for treatment, the United States and its partners, both international and domestic, public and private, defied those who claimed that providing antiretroviral therapy in the developing world was not possible. And we were just talking before about a couple of years ago, no matter where you went in Africa, there were so many groups there, both governmental, non-governmental. We saw all the foundations. Everyone was ready to work and ready to address these statistics. And Pepfar's update from May of this year does demonstrate our success. 1.1 million people are receiving treatment. We committed ourselves to treatment, and the results speak for themselves. Unfortunately, we have not been as successful in addressing the need for better prevention. In many countries, we've implemented a uniform prevention strategy that is often called ABC, A for abstinence, B, be faithful, C, use condoms model. Unfortunately, the cookie-cutter approach has not worked universally. And some argue that we're heading backwards in our efforts to slow the pandemic. And I know there are many groups, both domestic and international, represented here today. And as so many challenges here in the United States, wherever I go, and I just came back from 5 countries in Africa, you see incredible prevention programs, some really, really good ones. But somehow we are not replicating them on a scale large enough to make a dent. And frankly, this is what's happening in the United States as well, as you all know too well. We have an opportunity together to learn from these experiences and set a new way forward in the global fight against HIV/AIDS. As I mentioned, I visited 5 African countries in August, including Uganda. And while I was there, we spent a morning at TASO, the AIDS service organization, with which many of you are very well acquainted. We learned, we talked to people, we heard all about their treatment care, prevention programs, and we're all familiar with the debate surrounding Uganda's HIV/AIDS early prevention successes. Articles, conferences, experts continue to investigate, debate what may have been the magic prevention bullet. Some claim that it was the ABC approach. Others credit the strong sense of fear that spread across the country as they watched thousands of their family members and friends die, especially HIV-positive pop star Philly Latawa, who spoke publicly about his infection in the late 1980s, while others attribute success to the zero grazing policy. During our many conversations, I asked those who have been fighting the Uganda epidemic since 1987 what they thought made the difference, and their responses were striking. They reminded us of Uganda's long tradition of community, understanding. They talked about their efforts to educate their families and neighbors about HIV/AIDS so that they would choose to care for their brothers and sisters and accept them despite their illnesses. This education led to a general community understanding about preventing infection and halting transmission. It was some combination of these factors that led many Ugandans to change their behavior, to reduce their number of sexual partners, to lead healthier sexual relationships. This understanding, resulting from extensive conversation and education, is what they believe led to their initial success. However, unfortunately, recent evidence from Uganda suggests that the HIV incidence is rising again. Some working at TASO shared with us their belief that the introduction and availability of treatment was leading many Ugandans to see HIV/AIDS as a chronic disease rather than a death sentence. This same phenomenon is seen in many countries, as I mentioned before, in the United States as well. And we have a huge challenge, and we must work with all of our partners to develop prevention programs that will be successful. With the expansion of treatment, Pepfar must take a new look at prevention. And I'm sure you've had many of the experiences I've had in some countries, even with ABC, even with requirements that the donors have put on their grantees. Many people just ignored it because people were dying and lining up outside the clinic. So the focus for everyone has been treatment. So I do believe strongly that Pepfar must focus on prevention. What worked in Uganda in the late 1980s and early 1990s was a homegrown solution, one that was very specific to Uganda's culture and needs. And any future prevention strategy must be country-led and based on the culture and beliefs of that country. Of course, donors should continue to support efforts that utilize effective medical innovations, but in the end, the decision-making process, in my judgment, and program implementation must be country and community-driven. I understand that placing responsibility in the hands of others will make many of my colleagues uneasy. That's an understatement. As members of Congress, we like to provide clear direction and guidance. But I would suggest that we rethink this approach as we work to reauthorize the Global AIDS Initiative. I believe that we must put our trust in the thousands of men and women who work every day in their own neighborhoods to address the HIV/AIDS pandemic. And I must say, in addition to the homegrown talent, I have never met a more dedicated group of people than our citizens who work around the world on these issues. I continue to be impressed with their intellect, their commitment, their passion, their determination. And it is for this reason that I worked so hard in the fiscal year 2008 appropriations bill to provide adequate resources to the initiative and to provide flexibility in the way prevention funding is allocated. Countries must be empowered to design and implement prevention strategies that work for them, not a narrow Washington strategy that's based on the political agenda of others. As we set priorities for reauthorization of the Global AIDS Initiative, again, prevention must be a priority. In 2006, for every person who received treatment, another 6 people became infected. This statistic translates into an additional 60 million infections by 2015 if the world does not dramatically shift its prevention paradigm. The first Pepfar program changed the world forever by initiating treatment Our next program must reflect a true commitment to prevention. Treatment programs required an enhanced emphasis on accountability. This laser-like focus on results has led to really good outcomes. But I'm concerned that these results were achieved at the expense of integration and collaboration between the Global AIDS Initiative Program and USAID's ongoing health and development programs, which is another point that I want to emphasize. During my recent trip, I visited a hospital in Ghana, for example, that included a community-based maternal and child health program. This hospital and other similar health centers have achieved remarkable results, including a reduction in child mortality, significantly expanded contraceptive use as part of a comprehensive health approach. In fact, a recent UNICEF survey found that mortality of children under 5 is at an all-time low. We had hoped that the Global AIDS Initiative would build on these successes and incorporate lessons from these local health providers' experiences. Unfortunately, what I have found, not just in Ghana, in too many instances, the Global AIDS Initiative did not build on these successful models, but rather chose to create an entirely new vertical HIV/AIDS program and system. I see some shaking heads here. And in some cases, this was necessary due to the stigma associated with HIV and concerns that integrating HIV treatment into primary health centers would lead some women and children to avoid these clinics. Let me just say this. This is not just with HIV/AIDS. I'm looking at the whole delivery of services right now. And wherever we went, whether it was Ghana, Uganda, Kenya, Liberia, I asked for a meeting with everybody in the community who was doing anything connected to the work. I think it's absolutely essential that we meet with other international donors on a regular basis. And Peter and I were talking about how this is happening more often than not now. The foundations are doing amazing work. Individuals are doing amazing work. There are whole kinds of NGOs that are working. And I don't think years ago we were making a strong enough effort as was necessary to get everyone in the room and really coordinate so we can all maximize our dollars, our efforts, our manpower, our woman power, etc. It's better, but it's still not good enough. So, as a result, opportunities to build on best practices and strengthen existing health systems, I felt were lost there as a vertical system was developed next to the other system. And now, of course, we have AID programs, we have Millennium Challenge programs, we have Pepfar programs, and on and on and on. We really have to work together and coordinate better. And that's not even talking about what DOD is doing in these areas. So we have a lot of coordination to do. I mentioned before the education programs. As you know, for years, USAID has implemented basic education programs at the community level. In the early years of the Global Aid Initiative, an opportunity, in my judgment, was lost for more extensive collaboration between these departments. Getting young girls in school, keeping the young boys in school. What better way to deal with AIDS than providing that education? And I am pleased to hear that I think this has changed. USAID and the Global AIDS initiatives are working better together now to include age-appropriate HIV/AIDS information in the classroom, as well as provide HIV/AIDS prevention information to teachers. I am very pleased to see Administrator Hill here today. I expect that you will hear about the great programs that USAID is implementing to complement the investment of the Global AIDS Initiative. USAID's efforts are central to our success in stopping the pandemic. And as we consider the next phase of the Global AIDS Initiative and our response to this unyielding pandemic, We must broaden our thinking and ensure that comprehensive community-based approaches with a development perspective are incorporated into our strategic plan. Now, I mentioned education, I mentioned the hospitals, I could go on with agriculture, water programs. It can all go together. I remember a visit in Tanzania, in Arusha, and visiting a school. No water, no food, no books, barely a teacher. Just think what we can do with a school lunch program, with health programs, with fresh water, with trained teachers, and we can do it all together. To me, this is the important focus and must continue to be the important focus of our efforts. I'm a firm believer in U.S. government coordination, I guess you could tell. But that alone is not enough. As, again, I've learned firsthand, we have to coordinate better with the global community, with other donors, both public and private, as well as the multilateral organizations, such as UNAIDS and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. The success of these programs is critical. We must continue to be active partners in their efforts, and I am pleased that Congress has been able to support increased funding for the Global Fund and UNAIDS. I anticipate this will continue in the coming years. As you know, the Appropriations Committee will soon complete action, we think, on the fiscal year 2008 funding bills. I would like to say the House has succeeded in passing all the bills. The Senate has its own timetable. We'll see what happens there. We don't know if we're going to have an omnibus, a minibus, individual bills, but that's what makes this place a challenge and interesting to all of us who work here. One thing I'm sure of is that we will provide over $5 billion to address the global HIV/AIDS pandemic in FY 2008. And I'm very proud of this commitment. And as chairwoman of the committee, I have made, with all of my partners, combating HIV/AIDS a priority. I look forward to even exceeding the President's commitment of an additional $30 billion over the next 5 years. The decisions made in the coming months will determine the future of our global HIV/AIDS efforts, and I know that my colleagues working on the reauthorization of this important program will be courageous and visionary. So I look forward to supporting their efforts, working with them, working with all of you, working with our international, our domestic partners in ridding the world of this devastating disease. Thank you very much for all you do, and let me apologize in advance. Unfortunately, I have to go back to the Hill and fight on all kinds of other issues, but it's a pleasure for me to address you today, and thank you for your important work, both here and internationally.
Thank you very much, Madam Chairwoman. It's been a terrific pleasure to have you and host you here, and so thank you very much for your comments today. We will turn then to Dr. Piot for his remarks.
Thank you, Jeff, and thank you, Mike, for that very special introduction. It was the first time that been introduced as such an old man, but I've been introduced a few times as the man who's responsible for the AIDS epidemic in the world. So that was, so that's much worse. Anyway, it's a real pleasure to be back here. Indeed, it's the third time that I speak here at the center, and I've spent a lot of time in Washington over the years. And so this has been always one of the defining stops that I made. And the research and the activism at the center is really crucial for our campaign to fight AIDS. And it was really wonderful to hear Congresswoman Nita Lowey and give her perspective. And you'll see that some of the points that I will make are very similar to hers. And Kent, we've been good partners. We We've done many things together, and I think particularly in the area of prevention of HIV, where I really appreciate your leadership. A quarter of a century into this epidemic, we're really at a turning point. A turning point that I believe should force us to take a long-term view for a sustainable response, in addition to the much-needed crisis management that is still there, with thousands of people dying every day. What I'll do is I'll give very briefly a few trends in the epidemic, the response, and then give our perspective on the future and what we have to do. So what are the trends? First of all, the epidemic is still expanding. It's globalizing. We heard the figures from Nita Lowy. I won't repeat them. But something that is often not well known is that a disease that was not even known 26 years ago is now the 4th cause of death in the world. The 4th cause, after heart diseases, strokes, and respiratory illness. So it's not a marginal phenomenon just looking at it from that perspective alone. Secondly, there's the feminization of the epidemic. It's a trend that I've discussed here before, but it's continuing. In every single region in the world, the proportion of women among those who become infected with HIV is increasing. And it's true also here in the United States. Thirdly, we're starting to see the impact of this epidemic in the worst affected countries, where we're starting to see a sort of reverse development, an undevelopment, because of the tremendous human and social capital lost to this epidemic. We estimate that by 2010, the 5 most affected countries in Africa will have lost about 1 in 5 workers, employed people, because of AIDS. Some of the sectors in national economies are really getting into a crisis. For example, the mining industry in Botswana loses more than 8% of its profits every year because of costs related to HIV. And in the tourism industry in Zambia, which is one of the future assets of the country, HIV-related costs total nearly 11% every year. And we could spend a whole panel on the issue of orphans, of vulnerable children in Africa and elsewhere. I should say that we have gained a better understanding of the societal drivers of this epidemic. We've had, I think, a good understanding of the biological drivers, virology, things like male circumcision, but the societal drivers, which are basically the reason that we do have this epidemic, have not been studied that well. And unlike what is often said, AIDS is not just a disease of poverty. AIDS is a disease of inequality. Inequality, gender inequality being the most striking ones. But when you look at the HIV infection rates by income, it's the highest income in most African countries, that income category, that had the highest HIV rates. That is very unlike about any other health problem. When you look at maternal mortality, child mortality, and so on, there's a direct link with low income, with poverty. But that's less true for AIDS. And I was in China last week or the week before, and it is clear what is going on there. One day I was having a drink in Shanghai and with some Chinese colleague who speaks English, and he said, well, don't you know, we were talking about AIDS in China. Don't you know, he said, this is about 3M. 3M, I know the company, and he said, mobile men with money. And I would add mobile men without money as well. China has 150 million floating populations. The the poor workers who are constructing the Olympics, the buildings and so on, 150 million away from their families and so on, no access to services. And then you've got the entrepreneurs and the mobile men with money. So what we can expect also is that rapid economic growth and transformation of societies is also going to become a driver of the AIDS epidemic in some parts of the world. We're seeing that in Vietnam, we're seeing that in China, perhaps tomorrow also in India. So economic inequality, social inequality, marginalization of groups because of sexual orientation or drug use or whatever, immigrants, gender inequality, lack of access to service. All that creates a perfect storm. As I heard on a Tuesday at Howard University, where I also gave a speech, and where we were talking about the 5% HIV prevalence rate in the District of Columbia, which is higher than many West African countries. So AIDS is very different from other health issues, exactly because it's mostly transmitted by sex. And so we need to think of that also when we design strategies, which do have to be pro-poor when it comes to the role of international cooperation in the state, but it's a bit more complicated. And it again illustrates the exceptional nature of AIDS, and that it's unlike any epidemic that we've known. It's not just one of many infectious diseases. It really belongs in the league of climate change, nuclear threats, and so on. But what I feel is that why we're at a turning point is that today there is real hope. And it's evidence-based or evidence-informed hope. It's not just something that we wish will happen or have happened. It's supported by facts. We heard about treatment. Probably around 2.5 million people are on antiretroviral therapy today in the developing world. Remember in 2001 when we had a historic special session in the General Assembly on AIDS, which really was a turning point, another one, the last one, epidemic. About 100,000 men and women, particularly men then, were under antiretroviral therapy in the developing world. Most of them living in Brazil, because it was the first country in the developing world was offering treatment at state expense. So major progress. But secondly, is that we're also starting to see results of prevention efforts in most East African countries, even in Zimbabwe, in Cambodia, in Barbados, in the Bahamas, nearly on every continent except in the former Soviet republics. There's no decline yet happening. It's true, as we just heard, that in Uganda that we're starting to see a reversal in some communities, just as we're seeing it in gay communities in Western Europe and so on. But all this is really something that is new. It's for the first time since in the history of this epidemic that we're seeing this kind of real results on such a large scale. A less well-known, but I believe equally important development is that investments in the fight against AIDS are having an impact beyond AIDS. Let me give you just a few examples. A recent study done by FHI in Rwanda showed that those primary healthcare centers where basic AIDS activities were introduced and were added have seen a much higher coverage and uptake of services beyond AIDS, maternal and health services, reproductive health services, particularly. We're seeing also for the first time that there are investments in programs on violence against women, sexual violence, something that, of course, predates by far the AIDS epidemic, but had very little attention except some micro programs. So in many cases, it's the first time that long-standing issues really got some serious investments. And in that sense, work on AIDS is opening many doors for development. But despite this progress, we really cannot become complacent in our early successes. All these lives saved, all these results are the direct result of the significant increase in the world's commitment to fighting AIDS. When UNAIDS began its work in 1996, about $250 million was spent on AIDS in developing countries. This year we estimate it will be like 10 billion total, the world. Huge increase, unprecedented in development, I would say. While this is not still a sufficient sum, it's a pool of money with which we can do quite a bit, and so it's about time we're starting to see results. The world has established new mechanisms to fight the disease and the epidemic. The Global Fund to fight AIDS, TB, malaria is the main multilateral instrument for that, and it was created in 2002, and it is also starting to have a true impact on the lives of people. And next week in Berlin, there will be a replenishment conference for the Global Fund where all the donors are coming together to make their pledges, and that will be a test for the commitment of the international community again. But the most significant infusion of leadership, of money and commitment has come from the United States through Pepfar. And I would say that US leadership has truly transformed the global response to AIDS and the course of the epidemic, as we heard. It really enabled us to make a qualitative and a quantum leap forward. I remember when in 2000 at the International AIDS Conference in Durban, I called for a shift from the M word to the B word, from the millions to billions, because then we were talking about adding a few millions, maybe 100 million. I mean, it sounds totally ridiculous retrospectively, but when I called for that, I was getting real problems with some of the donors, saying that somebody in my position should not make this kind of irresponsible statements, and that in any case that money is not there. So 7 years later, $10 billion, and that's really in the first place thanks to American leadership. And I would really like to pay tribute to Mark Dybel and his team at Pepfar and all the many partners of it for having done the impossible, what appeared to be impossible. At the 2005 G8 summit at Gleneagles, the leaders of the most powerful economies of the world made a commitment that was incredibly bold, and to come as close as possible, as the text says, to universal access to HIV prevention, treatment, care, and support. And that was then taken up by the General Assembly of the UN, and this is really our ultimate goal. We cannot rest until the last person living with HIV has access to treatment. We cannot rest until we're reaching everybody with prevention activities and transmission is stopped. This is a crucial mission. But today we are not on track to achieve this. At the current pace, there will be fewer than 5 million people on treatment by 2010, just over half of the people who will need it. And when you look at the coverage of mother-to-child transmission prevention programs, they are very, very, very low in many countries, although some have done remarkably well, like Botswana. And this is not politically controversial. It's not about sex and drugs. So there is a bit of a problem there. So we must increase our efforts. So it's a turning point. Also a turning point here in Washington, a turning point in many countries because of a change in leadership, Congress. You're electing a president next year. We've seen in France, in Germany, in the UK, in Italy, a change of a prime minister or president over the last 12 months, 1.5 years. In Africa, President Obasanjo, great AIDS activist, is now also retired. So we are in a new area of leadership. I have a new boss, Secretary General Ban Ki-moon, coming after Kofi Annan, who was such a major AIDS activist, if you want, and great supporter. And I'm happy to say that Secretary General Ban Ki-moon also has declared this as one of the priorities for his tenure. But that is not a given. We have to work on that. And either we move forward in what we're doing, or we will be slipping backwards. That is the way it is. And sometimes I hear AIDS is done. Now, because that's the dilemma. When you have some results, people said it's done, and now we've moved to the next thing. And there are so many problems in the world that that's entirely understandable. But AIDS is not done. We heard it. And let me now turn what I see as as key issues for the next phase of Pepfar. And these are largely based on some extensive surveys that we had with our field operations, and where we have really an excellent collaboration on the ground with Pepfar. And I'd like to mention 3 areas, and some of them are very similar to what we just heard from Nita Lowe. The first one is building on Pepfar's successes is to promote a truly global effort through increased funding. So that's the first one. The second one is to add a sustainability strategy to our current emergency management and response. And thirdly is to maximize the effectiveness of investments through partnerships and better coordination. Okay, on the first point on funding. As I mentioned, this year, $10 billion more or less will be spent. This is only slightly more than half of the global need. If we're going to achieve universal access to HIV prevention, treatment, care, we will need a major increase in funds. As far as Pepfar's reauthorization is concerned, Congress will soon debate the funding levels for Pepfar over the next few years. President Bush has requested $30 billion, which works for $6 billion per year. That is a very large sum, to be sure, but more is needed. So I urge Congress and the President to go further, to continue on the same upward trajectory that Congress and the administration have been following during the first 5 years of Pepfar. And I'm not alone in calling for a significant increase. A recent Kaiser Family Foundation poll tells us that 60% of Americans say that the U.S. has a responsibility to spend more to fight AIDS in developing countries. So we simply can't afford to drop the ball now on our path to universal access to HIV prevention, treatment, and care. And why? What are some of the reasons? Just consider 5 points. One, the most obvious one, is that failure to increase efforts will not meet the increased needs and will result in far more deaths. That's one thing. But the second point, I think, is very important, and it's something we've learned in AIDS, and that is that for few issues in development, it's so true that it's act now or pay later. If we would have acted with the same resources and determination and political will that we have today, if we would have acted like that 10 or 20 years ago, the AIDS bill would have been much cheaper. There wouldn't have not only been less deaths, but we would have not have the disaster we have today. So if we delay increased investments now, 5 years from now, the bill will be even greater, particularly if we've continued to fail on HIV prevention. So that's a real major reason to act now. Thirdly, as I mentioned, AIDS action is key to improve health systems. Just, if only because in many countries 50% of hospital beds are occupied because of AIDS. So that in itself is being added to the already enormous burden on health systems in many countries, and if we can't reduce that burden through antiretroviral therapy, it's only going to get worse. But it's also essential to achieve many of the Millennium Development Goals. Fourth is that we will be more efficient in the future. A lot of energy and time has been invested in setting up systems. Supply chain management, procurement, community activities, and we'll have more economies of scale in the future, and building on that. And lastly, earlier investments that have been made, very precious ones, as I just mentioned, they will be lost if we were not going to continue on the trajectory, as I said, that we've been on for the last 5 years, a very good one. And as a European, I can also say that putting more money into Pepfar will compel the rest of the world to do the same. We saw that when President Bush announced in his State of the Union in 2003 that, this country will put $15 billion on the table in the fight against AIDS. This was followed by others. The first one being the UK, and then others. And this has happened again and again. And that's the power of American leadership as well, which may not be visible here in Washington or generate more credit here in Washington, but from a global perspective, that I know is extremely important. I would say that all these are very compelling reasons to go beyond what is being done now and not go for a more or less flat continuation of the effort. Second point is that in addition to increasing the funding, we must maximize the effectiveness of our investments through partnerships and better coordination, a point that we just heard from the Congresswoman. And we must more to make that money work for people on the ground. So it's not only more money, but also making sure that the money is there, is spent more efficiently, that we get more for that. And making the money work is our mantra in UNAIDS. That's what every staff member knows. That's what we are working for in countries, in partnership with Pepfar, but particularly also with the Global Fund. It means maximizing our effectiveness by improving coordination among donors, government implementers, and so on. And we have a framework for that, the 3 ones, as you know. And Pepfar and other efforts have had their greatest successes, for example, in Rwanda, where governments are full partners, and the US effort is fully integrated with national strategies. All this may sound a bit tedious and even bureaucratic, but it means a difference between fighting AIDS effectively or losing ground. And finally, the third point is that this is the time to add a long-term view and sustainable strategies to the emergency response, the E in Pepfar. And the emergency response was and remains absolutely necessary. But such a shift has a number of implications. First, it means supporting a country-driven and flexible response that allows for an enhanced focus on prevention. And I won't repeat what Congresswoman said, but for every person who's put on antiretroviral therapy, 6 become infected with HIV. So to get ahead of this epidemic, greater investments in prevention are absolutely essential. And it must be according to the epidemic in the country and the cultural and social context. It means also to minimize programmatic set-asides to foster an appropriate balance among prevention, treatment, care and support in each country, and increase support for evidence-informed prevention strategies, solutions that work. As I've said so many times, anything that has the word only in it doesn't work for AIDS. But it's treatment only, prevention only, condoms only, abstinence only, male circumcision only, and you have a long list. I get all these letters saying, if only, Dr. Piot, you would do this, we stop this epidemic. We need it all. Another implication is that it means investing systematically in countering the drivers of this epidemic. I mentioned them, inequality, stigma, and the one I'd like to highlight is gender inequality. which is the major driver in many countries, and where we need to have a far more rights-based approach in it. This is dramatically illustrated, of course, by the feminization of the epidemic. And yesterday I was at the CSIS at a panel on gender and AIDS and Pepfar, and Geeta Rao Gupta summarized it all, and she said, it can be done. This is not something that is a hypothetical intellectual framework. It can be done. We have examples, for example, how violence against women and male attitudes and behavior can be changed, like from the Stepping Stones programs in South Africa and elsewhere, Image, and so on. So I urge everybody working on AIDS to ask ourselves, does this program work for women? If our work doesn't work for women, it doesn't work at all. And a third implication, and then I'll conclude, is that we must invest also more in strengthening the systems that to deliver. Health systems, human resources for health, absolutely, but not only that, because when you take AIDS, HIV prevention is largely happening outside the health sector. It's not going to be fixed by more doctors, more nurses. It's outside. So we need to invest also in the capacity of communities to respond, indigenous communities, and also how countries can manage their programs. So let me conclude saying that we have, without any doubt, made major progress in the fight against AIDS worldwide. And this is a real great tribute to American leadership. But today, as we prepare for the years to come, and as we make our budgets and formalize our plans, we must commit ourselves to not simply continuing our efforts, but intensifying them and also adapting them to the new reality on the ground, the new reality that we've all, created because of our impact. And I know we cannot predict the future, but we can create it. And the mark that AIDS makes on history from this day is not out of control. We have the evidence now. It's largely in our hands. So my question is really, Washington, are you ready for another breakthrough in the fight against AIDS? Thank you.
You'll be relieved to know that I've left my speech at my desk over here. That's not quite as noble as you might think. I'm having eye surgery on Tuesday because I see twice as many of you as there are here. And if I saw twice as many of my notes as I have, that would be very dangerous. So what I would like to do instead is to focus on 4 key areas. But before I do that, let me thank the Wilson Center for inviting me to be here, and I admire the work that you are doing. I admire your passion for this topic on HIV. You've thought about it for a long time. You've hosted a lot of things. It's very important. Appreciate the effort you have given to looking at Pepfar and having dialogue about that. And I also want to mention that something about the Congresswoman who spoke earlier. I've worked with her on a lot of issues, avian influenza and other things, and she's one of the most knowledgeable, committed people on the Hill. Like her predecessor, Congressman Colby, we're very fortunate that from both sides of the aisle you get people who are as committed and knowledgeable about important health issues as these folks are. And so it was a privilege to have her here and to continue to work with her. And as for Peter Piot, I have grown to really respect Peter in recent years. He was really ahead of the curve internationally in recognizing the fact that we just weren't making enough progress on the prevention. He co-hosted in Geneva, I guess it was last September, a major effort bringing 25 or 30 experts from around the world to ask the tough question about what could we do differently in terms of the drivers of the spread of this epidemic. And there were some very interesting results from that meeting that if I have a chance I'll say something about in a few minutes, but it was the leadership of Peter that made that meeting possible. And if we have some success for the next few years, it's going to be because of that sort of leadership. But the 4 issues I would like to just briefly touch on with you this morning. I want to say something just in general about the U.S. efforts on this and what it means and how it's broken down. I want to address the question for a minute, what are the multi-sectoral dimensions of fighting HIV/AIDS, because it's more than a health issue. And in fact, that was the specific issue, Jeff, that you asked me to deal with, and so I want to say something about that. And third, I want to talk about turning off the tap, about dealing with what the Congresswoman and what Dr. Piot talked about, which is how do we actually begin to turn back this incredible number of new infections every year. And finally, just a quick word about cooperation and collaboration. Everybody knows that the President made a commitment for $15 billion originally. What folks I'm not sure are as aware of is that the actual total for the 5 years may be closer to $18.3 billion, and that the request level for 08 is $5.4 billion because of the nature of the scale-up. And of course, more recently this summer, there was the commitment to go for doubling that to $30 billion. Just to give you a real quick snapshot of something I think you understand and know, how does that really break down in terms of what the USG does with those funds? In 2006, about half of those funds went for treatment, and there's been a tremendous scale up in those who are receiving treatment. About 28% of that went for care, palliative care. It includes things like OVC, orphans and vulnerable children. And then the remaining part, about 22%, is prevention. And that expands to about 28-29% if you were to include all the counseling that is done that will have a prevention component. Of that prevention, if you take the total HIV monies spent, about 7% goes for sexual prevention in the categories of abstinence and be faithful. There's almost no abstinence only. It's usually in conjunction with fidelity programs or partner reductions as well. And then there's another 6% or so that is condoms and other sexual prevention activities. So a grand total of about 13% for sexual transmission involving A, B, and C. And I think the Congresswoman is right, and Peter's right, and others are right that are saying that in this next iteration of what the global community does, if anything, we're going to have an increase in the amount of effort and the quality of the effort on prevention to make a difference there. Now let me say something about the second point I said I wanted to address, the multi-sectoral point. People think that the work on HIV/AIDS has to do with just those categories I was talking about, and that when Congress gives money to Ambassador Dybel and Pepfar, that's all it goes for. There isn't anything for the so-called wraparound programs. And I want to suggest to you today that that could not be further from the case. We have learned painfully sometimes that we've known it for a long time, and even the authorizers of the original bill in 2003 had some language in the bill, I don't have it right in front of me here, which talked about allowing related activities. Now, why did they put that in there? They sensed even at the beginning that it's not just the treatment and the prevention, etc., that's important here. There are related activities. Now, what am I talking about when I mention that? Peter mentioned, Congressman Lowy mentioned, and we've all been talking more and more about gender issues. You can't talk about abstinence and being faithful and use of condoms, etc., if women don't have the freedom to make choices or respond to any of those interventions. If you don't have a robust gender program to deal with the inequities, the inequalities between men and women, all the talk in the world about condoms or being faithful or abstinence doesn't work. When you have transgenerational sex in Africa, where older men are putting pressure on younger girls to engage in sexual activities when they don't want it, you better deal with male behavior. You better figure out a way to address those issues there. Therefore, gender programs should not be disconnected from HIV/AIDS programs as a different category and different money. Sure, if you can get money from other sources, take it. But it's legitimate to use some HIV monies to address gender issues. Or take the issue of orphans. Everybody says you need to address orphans. Well, yeah, you need to address orphans, but what kind of needs do orphans have? Orphans are 3 times as likely to die because of being without parents as kids with parents. And that's not just because they might end up being HIV positive. They're 3 times as vulnerable to death. They are less likely to get education. If you don't have education program for orphans, if you insist on viewing education programs as disconnected from HIV, you won't meet the needs of orphans who are the byproduct of the HIV pandemic. You have to address education. You have to collaborate with those who are doing education. Or take the issue of nutrition. People say, that's humanitarian, that's not HIV/AIDS. Nonsense. You can't do treatment for people who are on ARVs if you don't recognize that the impact of that treatment is going to be impacted on whether people have enough to eat. So you'd better be cooperating with, or if possible, even finding some funds for nutrition programs to address that. Or take the issue of economic growth. People say, well, what does that have to do with HIV/AIDS? It has a whole lot to do with it. It has a lot to do with it. HIV-positive people are often discriminated against, as Peter has noted. It's sometimes hard for them to get jobs. It's hard for them to keep jobs sometimes. Sometimes they can't work as easily at first as others. That you need to address their needs. With the orphans, you need programs to train them to do things when they get older. You have to address employment issues. You have to address economic growth issues. Or take health systems. You don't just address HIV by coming up with drugs. You have to improve the health infrastructure. You have to think about whether there are enough people out there to not just deliver the services. And if you help in this area, by the way, you will help in every health intervention, not just interventions that involve HIV/AIDS. Or think of family planning. Some say, what's the connection between family planning and HIV? Let me tell you what the connection is. If a woman is HIV positive and she's pregnant, she not only needs to be tested to make sure that if she is positive, she can take some actions that might have an impact, will have an impact likely on whether her infant, her child, will be HIV positive. She needs lots of other things as well. When you meet with a woman who's pregnant and HIV positive, you can also help her a lot by giving insecticide-treated bed nets, for example. You can help her if she doesn't want more children and she wants to space her children by directing her to or helping her gain access to family planning. USAID since 2002, for example, between 2002 and 2006, I think, or maybe it's 2007, we've increased by 63% the amount of family planning money that we are moving to the Pepfar countries. That's where the need is particularly great. To the extent we've done that, that has a positive impact on HIV-positive women. They're connected. Now, the pot of money that goes to help them may not be HIV, GHAI monies, the money that goes to Ambassador Dybel and then usually on to USAID or HHS and CDC or the Peace Corps or whatever. You can use other pots of money to do things that will make a difference. There's cooperation going on right now, for example, with the President's Malaria Initiative, which is being headed up really very well by Admiral Timothy Ziemer. There's coordination going on now with the President's Malaria Initiative and Pepfar to make sure that those programs work very closely together. My main message here in this second point is you cannot think of HIV as simply an isolated one particular part of the health agenda. It's connected to lots of other development matters that you have to address at the same time if you're really going to succeed. Let me say something about prevention. It's getting fashionable now to talk about prevention, and that's good news. But the cold, hard facts are, and it doesn't matter if it's Gates speaking about it or former President Clinton in Toronto, it doesn't matter if you're talking about Democrats or Republicans, anybody who can add, anybody who can look at the numbers knows that something has gone wrong when you still have 4.3 million or so or 4 million new infections a year. You could increase significantly, as we have done, the number of people on treatment. You could double every several years the amount of money that's going into this, and you can't keep up with the treatment demands that are going to be out there. If you do not, as I heard one World Health Organization person put it, if you don't turn off the tap. We have to stop this unfortunate arguing about ABC and the prevention methods, etc. One of the reasons I think that Pepfar and the USG and others who understand the importance of condoms and partner reduction infidelity and abstinence for younger folks, the reason I think they're right to emphasize all three is because we're being criticized from all sides at the same time. I have to deal with folks who don't like us being the biggest sort of exporter, in a sense, of condoms in the world. I have to deal with other folks who don't like us talking about sexual behavior. But if you're a public health expert, you have no choice but to do all the interventions you can possibly do, and not just A, B, and C. Now we have the opportunity to move forward on male circumcision. We have the need and the opportunity to work for on gender issues, and all these things are going to be connected to any success we have on prevention. The tricky thing is, how in the world do you increase the percentage of the resources you spend on prevention when there are so many other compelling needs? And that's the painful question that people at UNAIDS and the Global Fund and Pepfar and USAID and everybody else that works on these issues has to figure out what to do. But do the math. If we don't do better on prevention, we won't have the resources to deal with the number of orphans and the number of people who need treatment. So I think it's appropriate to say that we need to move forward faster and more effectively on prevention. Let me say one more thing. I promised I would say something about what Peter chaired in Geneva, one of the results of that. Well, we've noticed, for example, that there's some interesting things going on in the prevalence rates. And by the way, one size does not fit all, as the congresswoman put it. You don't have the same strategy for a country in Southeast Asia with a focused HIV prevalence rate mainly found among prostitutes or sex workers and drug users, such as in much of Central Asia and Russia, and a place where you've got general prevalence as we do in some countries in Africa. The proportions of A, B, and C change. You have a lot more emphasis on condoms in places where you're dealing with sexually active people doing or engaged in risky behavior. You have different messages if the problem is elsewhere. You have to tailor your response to the place in question and come up with the right answer. But we noticed a very interesting fact. It was mentioned by the Congresswoman that Uganda had had some success, partly because of political leadership. And we noticed that it dropped from the 20s to 7 or 8% prevalence. And now, disappointingly, it's kind of leveled off lately, and people there tell me they've sort of backed away from some of the messages that helped them initially. But Kenya went down, Zimbabwe's gone down, Uganda's gone down. There's been improvement in some areas of Southeast Asia. But other areas, particularly in southern Africa, the prevalence rates have been much more stubborn. And we've asked ourselves, why do some areas go down and some areas stay the same, or just disappointingly stay the same? And it's not condoms, because some of the places where it stayed the same, the distribution of condoms is higher than any place else in Africa. And one of the conclusions of the experts is that it has something to do with the phenomenon of concurrent multiple partners. A lot of times people associate the spread of the disease with casual sex, or visiting prostitutes or sex workers. In fact, in much of southern Africa, it's stable relationships with people you know, and it's in a number of relationships, 2, 3 partners. And what sexual networking studies have shown is that when that pattern exists, because of the way the disease spreads, spreading particularly quickly in the first 6 weeks of infection, if there is a network that's open with lots of partners, even just 2 or 3 partners, even something like 1.74 partners, it goes up exponentially. Serial monogamy, lots of partners, is not nearly as dangerous as concurrent multiple partners. Now, if that's what the evidence says, we better program effectively to get that message out, and then perhaps we can begin to see rates come down from the 30s and the 20s and lower, and go lower, and that will affect what we're trying to do. We have to program more effectively with that specific thing in mind. And fourth and final point I want to say something about is the importance of cooperation and collaboration. I know there are times when the international bodies and the bilaterals and others, and even within the USG, for goodness sakes, that agencies don't always cooperate as well as they ought to cooperate. But I must say, after 6+ years at USAID and about 3 of them in the Global Health Bureau, and watching internationally and sitting on international bodies, etc., I guess I am pleasantly surprised about how much goodwill and desire to cooperate there really is. And I think there's a lot of progress being made. Last couple weeks ago, I was in London at an event with the Prime Minister of the launching of a new health initiative that Prime Minister Brown is involved in, and I talked with Michel Kazachkine, the head of the Global Fund. He told me that never had relations been better between Pepfar and the Global Fund. There is sort of a meeting of the minds on many, many things. There's a lot of, we remain their biggest funder. There's a lot of cooperation going on. If you sit in, as I must sit in, on the approval of the operating plans for the 15 Pepfar focus countries, you know that no plan can get through the USG, can get through Pepfar, if it doesn't answer two questions. One, how does what we are proposing to do fit with what the other international donors are doing? Show us that this is not duplicative. Show us that this meets a gap. And then the second thing is they want to concretely see how that works out in practice. If the people who present the plan can't tell us what the others are doing and how we're collaborating, it gets sent back. Now that's the commitment to collaboration you simply have to have if this is going to succeed. So actually I'm quite optimistic that we are making progress on this front, but we need to be more aggressive in making progress, particularly on this prevention thing, so that we can divide the turf up. We don't have enough money to do everything, so we really need to do as well as we can on that. You know, this is a really big issue, and we've got to not have tunnel vision when we look at it. We have to connect it to all the other development issues that we have something to say and do anything about. And I think if we redouble our efforts, and not just our money, but if we work smarter and we cooperate better and we focus on prevention and deal with some of these prevention drivers that we haven't spent enough time on, we can make a difference. But it's going to require all of that for us to succeed. So thank you very much.
Well, thank you very much to both of our speakers. They've given us a lot of very substantive things to think about and to think over and have a dialogue about. So we'll turn to a Q&A session now. I ask that you wait for one of my colleagues to bring you a microphone so that we can all hear you here in the room, but also so that our audience in the webcast and the video that will be archived on the Wilson Center, so those folks can capture it as well. So when we start with Jim Shelton.
Yeah, hi, Jim Shelton, epidemiologist with AID. Peter, for 2 years, I've asked you about male circumcision, but this year I'm not going to ask you about that because I'm pleased to say that you're actually providing quite excellent leadership in that, and I want to commend you for that. But there's something else I'd like to see you provide some more leadership in as well, and it relates to kind of one of Kent's key points, which is in this prevention turning off the tap conundrum. As a technical person, I really find this evidence that it is multiple concurrent partners that really drives, it's the key driver of these generalized epidemics. And I really think the field in general needs to address it a lot more. I would like to see you address it a lot more, because when I see the sort of things that you're doing and what your publications have, for example, you have a publication, fairly recent one, on practical guidelines for intensifying HIV prevention. I have a hard time even finding partner reduction or this issue of concurrent partners even in that document. There's counseling and testing, there's condoms, there's gender and poverty, but I think we're really missing a fairly, not that it's the one solution, but it is in many ways the key solution is behavior change on this concurrent partnership issue. So my question is, isn't there something more you could do on that area?
Okay, shall we first
Why don't we take a couple? So Jeff Spieler down here in the middle, and then we'll move over to the lady over.
You're getting it from AID right now. Jeff Spieler, Science Advisor in
You
Population
brought all these
Reproductive
people
Health.
with you, Ken?
Stack the audience
They were
here. That's right.
I really enjoyed Nita Lowy's presentation, Peter, and Ken's presentation. They were marvelous, and there's lots of things that we could talk about. I'll just deal with one. Jim dealt with one. I'll deal with another. Peter, you happen to mention that PMTCT is not a political issue. I think I heard you say that, but I might have misheard how you said that, actually. But I heard Kent talk a little bit about family planning. I'd like to see more leadership on track 2 of WHO's approach to preventing maternal-child transmission, and that is preventing unintended pregnancy in HIV-infected mothers, HIV-infected women. So there is a firewall in Pepfar right now, to some extent, between what HIV money can be used for, counseling, referral, and there isn't a lot of POP money out there, population family planning money. And I think it's a very legitimate expense, and I'd like your reaction to two things, Peter, to use some of that money to ensure that at a testing site, at a site where HIV-positive women are seen, they don't have to be referred or sent away or sent to another site or told to come back, to have immediate access to contraception when they need it. And I'd like to know what more UNAIDS do to push that extremely important approach. Two models have been clearly demonstrated the most cost-effective way to prevent HIV-positive women from transmitting HIV to their children is to prevent unintended pregnancy. Much more cost-effective than nevirapine. Thank you.
So, Peter, I hope you notice that's a USAID question directed at me as much as you.
Okay, yes, please, there, and then the lady in the white.
My name is Paulo Lira and work with the... Sorry. Paulo Lira with the Pan American Health Organization. My question is about, as the U.S. response is expanding in terms of resources, I wonder if there is also any possibility of a consideration of expanding in terms of geographical scope. And of course, my interest is the region of the Americas. Yeah. Dr. Piot was saying that AIDS is driven by inequality, more even than poverty. And we have the most unequal region in the world. So I think there are a lot of needs, and yet a lot of Latin American and Caribbean countries, because they are considered wealthy, they're not eligible for Global Fund grants in certain cases. So, and yet they have very good responses, and there is a lot we can learn from this region, even in terms of scaling up to other regions. In the last 5 years, we saw many countries in Central America moving from a concentrated epidemic to a generalized epidemic. So this happened during the first interaction of Pepfar. I'm not saying Pepfar is responsible for that, but maybe this is a red light that we should be looking at, and it's part of a global responsibility. Thank you.
Terrific. And if we could get one more from the lady in white there, then we'll give you gentlemen a chance to respond.
Hi, I'm Meredith McGehee. I work with the IAVI, the International AIDS Vaccine Initiative. Both the Congresswoman and Dr. Piot talked about prevention and increased prevention, also about turning off the tap, but there wasn't discussion about an AIDS vaccine, and I wanted to know if that's because you are not as optimistic as maybe you once were, or in a way it seems like the ultimate way to turn off the tap, and where that fits in these prevention efforts.
Terrific, thank you. Peter, would you like to kick off this round?
Yeah. Thank you for these questions. And first on the whole issue of prevention and how to do that, Jim, we are devoting a lot of attention to it, and as Ken mentioned, consultation, meeting, but we are struggling with the how, to be honest. And it would be, I could easily say, okay, let's include that more in counseling and programs, and that's being done, or have billboards, but that's not going to make it. I think it's about changing societal norms. That is going to be the long-term solution to that, and that's why I would say it has to be connected with the gender issue. The problem is also, I mean, it's the latest fashion. And we have to be very careful that, as Ken just said, that we need to act on the epidemic in each country. Know Your Epidemic is the publication that you refer to, does mention multiple partnerships, and not in the sense of organizations working together, but going to bed. That's why we should probably not use that word too much for our institutional things. But it is really... I'm serious. It is really how to do that. I mean, promoting condoms is quite straightforward, the social marketing approach and so on. Delaying first sexual intercourse. I mean, I think we have a lot of experience in that with mixed results, but at least there it's clear. But changing the societal norms that's where I think we need to, I would say that's not in the domain of public health anymore. We are here, we need the expertise from people who are it's a combination of marketing, but also of anthropologists, social workers, political scientists are probably more important than people like me, and how to do that. I think that that's when the facts are clear for some countries, and yet again, let me emphasize that if we're going to say that in South Africa and Southern Africa it's all concurrent partnerships, and then others will say, oh, it's all male circumcision or the absence. I mean, it's many things. And there is still a need to focus our interventions there where the highest risk of transmission is, which is also there. But we are now confronted with a really diffuse situation in many countries. When I saw data from Zambia, and I think from Kenya also, that is it 80 or 90% of all recent infections are occurring outside so-called high-risk behavior. That's an incredible challenge. Even in Cambodia or in Thailand, is it half? I can't remember the statistics, but half of all infections are in married women who are supposedly negative, although I must say, when you look at data in discordant couples, it's not only the women who are infected by their husbands, there are also husbands who are infected by their wives. And I know that's a taboo at the moment, but we have to also make sure that what we see, is reflected in our messages. Otherwise, again, we will miss the boat. And that's probably the next thing. So I don't have a clear message on it, except that we do include it in the work, but I'm not satisfied by it, because I feel it's not practical enough. It's a big gap. There's a big gap between an epidemiologic analysis and observation, which it seems pretty solid, but then what to do about it? I mean, we're facing the same thing with male circumcision. I mean, when I hear some of the colleagues who do the clinical trials, I can only conclude that there is an incredible degree of naivete, and then I wonder on which planet are they living, where the step between the result of a clinical trial to the real world is enormous. I mean, anybody who's tried to do this work in development knows this, or in anything. So we need to devote far more attention to the how. And on the mother-to-child transmission prevention, I don't think I said it's not political. It's not controversial. It shouldn't be controversial. Let's put it that way. For the same reasons as prevention of sexual transmission is controversial in about every society, some aspect of it. But it's, of course, ultimately it's all about politics. That's for sure. If Botswana can achieve an incredible low rate of mother-to-child transmission prevention, why can't other countries do it? Why can't neighboring South Africa not do it? I mean, there is this is not a technical issue. It's an issue of leadership. It's partly an issue of some countries that health services are incredibly overburdened, and anything that you add has a cost, and what usually means you reduce something else. But I agree with you. Ideally, if women are not infected with HIV, there is no transmission to the babies. I mean, that's as simple as that. And I couldn't agree more that access to contraception for unplanned pregnancies is definitely should be part of the package. There's no if we only are focused on the nevirapine or whatever it is, that's not going to solve the whole problem. But when you look at increasing rollout of antiretroviral therapy, that in itself is also going to reduce mother-to-child transmission. But I think this is something that can be close to be eliminated. And if we would join forces to pay more attention to it, it will have major benefits. If we add or we integrated better with mother and child health. For example, I saw in some countries that women are tested for HIV when you go for antenatal care, but there's a very high syphilis prevalence. Now, it's extremely well documented. One, that syphilis causes stillbirth and so on, mortality, so on, and that it's easy to prevent. Talking about evidence-based, no problem. So, and that is at a very, very low cost. So that's the kind of things that illustrate what Ken said, that where we have to connect the dots. And then we'll have better results. It's not easy to do because there are the funding streams, the institutional streams go against that. But for an individual, for a woman who's pregnant, she couldn't care less, and it's actually a hazard to her that all these different things happen. So that is, I couldn't agree more. And we have some opportunity also with the Women Deliver conference, and that's coming up in 3 weeks, something like that, in London, which I hope will give a boost, a shot in the arm for women's health, for maternal health, and then for children's health. On the expansion of Pepfar, I'll leave that to Ken. But let's not forget that there is an absolute responsibility for our partner countries to invest in social issues, in health, in fighting AIDS. African countries have made a commitment in Abuja in 2001 to spend 15% of their government budget, to health and AIDS. How many have reached that? A few. And like Botswana is now 22% or so, but because of AIDS, but means that this is diverting enormous resources from what it could use for something productive for development of the country. But most countries are closer to 5% than to 15%. In Latin America also, some countries are doing quite well. Others have incredibly low expenditures for health. So that's one thing. And secondly, we have the Global Fund that is operating all over the world. But the key, I think, a problem for Latin America and also the Caribbean is that middle-income countries that are just middle income and are therefore not eligible for most favorable conditions for donors of all kinds. That's an issue. Why was a vaccine not mentioned? Not because it's not important. I'm a founding member of, I'm one of the founders of IAVI, so I'm really convinced of that. But simply because of when we talk about our strategies today and what we have to do, there is none. And it's really an issue for research that has to be intensified, and I think that is going into the right direction. Even efforts of better coordination through the HIV vaccine enterprise and so on. But and I also don't believe that the vaccine will be the solution. As such, it will be one of an area of prevention instruments, unless the vaccine is 100% effective. But according to the IAVI publications, the most likely strategy is really that this will be a major component of, when it's there, of the ever-expanding arsenal of prevention methods. I mean, frankly, that is also a big, big issue. I was in South Africa in June, National AIDS Conference. All the talk was on male circumcision. No presentation on access to condoms, nothing basically on anything about starting later with sex, a little bit on, on reducing partners or concurrent partnerships, because it was the latest thing, and particularly when it's a technology, if you can call circumcision technology, but anyway, it's an intervention. You do something and it's done forever. That is, I think, a danger. We see, there was an article last week, or I think in PLOS Medicine, about pre-exposure prophylaxis. Say if you give a pill a day to millions of Africans, we will save, I can't remember, millions and millions of lives. How to add all that, if it's available, and if it shows to be effective in controlled trials, that is in itself also quite a nightmare. And we have to be very careful that we don't throw away what we know that works, and build on that and see how does it fit in the bigger picture. So, thanks.
A couple of quick points. On the issue of, is there any possibility with the increased funding for Pepfar that we'll be able to divert more money from the so-called focus countries, most of which are in Africa, obviously the 12 of them are, to places like Latin America, the Caribbean, etc. Obviously, a place like Haiti is of interest, but the cold, hard facts are, and it's always going to affect the distribution of the funds, is when anybody takes a look at the list of countries and then they look at the percentage, the prevalence rates, etc., it's going to be very difficult to move a lot of funds away from places where the prevalence rate is 20, 30 times as high as in most places, the vast majority of places in Latin America. That's not arguing against the importance of doing something. It's not arguing against the fact that you could, in fact, and you better be watching the warning signs that something's going the wrong way. I personally think, and I know Ambassador Dybel feels very strongly about this, there is a pretty robust part of the Pepfar program that is non-focused countries. And it doesn't get the attention, but there's millions of dollars being spent in places where the prevalence rate is quite low. I'm particularly worried about a place like Russia or Ukraine, for example, where it's concentrated right now among drug users and to some extent sex workers or prostitutes. But I think all the signs show that this could spread to the general population very quickly. And once you get to 1 or 2%, they talk about an exponential factor occurring, which makes it much more difficult to get this genie back in the bottle. I think we ought to get ahead of the curve in places like Russia and Ukraine, invest in strategies even for the general population, because there's all sorts of signs that there isn't the check on sexual behavior that would stop it if it starts there. And so you better think about that. There may be some places in Latin America that are like that, and without spending an enormous amount of money, you could leverage the funds, you could do some targeted interventions that will never compare with South Africa or Kenya, where the two biggest Pepfar countries right now, but still could make a difference. So I think we shouldn't take our eye off of Latin America and other places, even if the prevalence rates are low. And then the second and final point has to do with this issue about what do you actually do on the prevention matter. It occurred to me that we talked about the fact that sometimes it's spreading not with risky behavior. Well, if you think about it, what are the three things that we usually associate with risky behavior? Homosexual activity is usually perceived that way. Activities with sex workers or prostitutes is casual sex, one-night stands. These are the normal things that we talk about. But when the empirical evidence mounts that there's another form of risky behavior called concurrent multiple partners, the fact that you know and have a relationship with somebody over a period of months and that it's an affection, it's a relationship of affection, even support for the family, and you don't perceive it as risky, it doesn't make it not risky. It means, though, you're going to have a public relations campaign to explain to them why certain conduct is actually dangerous to them. So the challenge is to help people realize that some things they don't perceive as risky actually are problematic. Now, having said that, let me add what's the hard part to this. I've never heard anybody talk about it, but we better face the issue. These are long-term relationships. Sometimes children are being taken care of in the relationships. These people they wouldn't view themselves in relationships of exploitation, although the women may be economically disadvantaged. What if you succeeded and you stopped concurrent multiple partners overnight? South Africa has a huge unemployment rate. If stopping these relationships meant that all of a sudden tens of thousands of kids and women no longer had the financial support that actually come from those semi-permanent or permanent relationships, that wouldn't be very responsible. You need to think how, at the same time you address a health risk, you deal with the social consequences of changing patterns of behavior. And that brings me to my last point. You know, we spend a lot of money on microbicide research and family planning research and condom research and all sorts of things, and all of it's legitimate. It's the right thing to do. You're trying to figure out the best way to do something. We have spent far less money on behavior change research.
Right.
We haven't hired cultural anthropologists to answer the question, okay, in Southern Africa, this is the problem. But we can't just say it's a problem. You have to tell us why this situation exists and what can we say that will help make a difference. Now, we just put a small amount of money with a woman, a professor in KwaZulu, University of KwaZulu in Durban, to come back to USAID in a few weeks with some proposals. And she's going to work with David Wilson at the bank, who's an expert on prevention sorts of things. But frankly, it's a minuscule amount of money, and we ought to take much more seriously engaging the best academics and cultural. I'm not talking about waiting 5 years for a big study. We know there's a problem, but some of these people know enough that they could help us pretty quickly, and then on the basis of that, we could program more intelligently. So I think we need to take more seriously the pre-work before we even develop the programs to address some of these problems.
Well, we've gone a little over, but I think there were rich questions and obviously a lot that our two speakers could say. Please join me in thanking them, and I hope that you will come back and continue to be